Great.
viewing audience. Most people actually watch it on YouTube and don't even enter the webcast. So don't let the numbers deceive you.
Great. Okay.
Most people actually watch it on. Okay.
Can you see the numbers that are connected later on?
One second. One second. Okay, here we go. 10, 9, 8, 7, 6, 5, 4, 3, 2. Good morning from Miami Beach. This is Dr. John Bennett, broadcasting here from the shores of Miami Beach. This is a little island off the city of Miami. We have the pleasure of having a longtime associate, Luis Lopez Zibor. We've done lots of webcasts with him in the field of neurointerventional radiology for years. And he has a special guest today. I'll let Luis introduce him. Welcome, Luis.
Okay, thank you, John. Thank you for your support and your channel. I present you in this session Professor Gyula is from Hungary, but he'll work in Denmark, Odense, and many places. I know him about more than 20 years, and the typical characteristics from Gyula is the discussion, because he work is not pontificia, is not orthodox, is free. He work free and present their experience. Please, Reynaldo, you introducing a little bit Gyula, okay? And then you talk, Gyula.
Morning for everything. Thank you, and welcome back and one more time to the new neuro table. We have this in this time a great guest, Professor Gyula is a consultant of the university and hospital in Denmark. He is a great pioneer in the stroke treatment and in the work. He is working and pioneer in a rapid pulse cycling association system in the treatment of the stroke. Today the topic is about the communicable artery complex aneurysms in the brain and the anterior communicating circulations. If we have a little remember this kind of aneurysm, while overall prevalence in the intracranial aneurysms in 1 and 5% in the population. This kind of aneurysm have a higher of rupture compared with the other position aneurysm, with a higher mortality. And when this kind of aneurysms have been with rupture, the rate upon rupture is very, very bad, with a great hemorrhage and death in the patient. So the floor is your Professor Gyula. You're welcome. Please, we'll start this topic. Thank you so much.
Thank you very much. So now I shared my screen and I will click on the PowerPoint. Hopefully, I try to make it bigger. How do I do that?
Okay.
Can you see? Yeah, now.
Not yet. Okay.
Better now?
Not yet.
Two times to connect.
You have to click share.
So what do I do? Screen sharing meeting?
Not yet. You have to click share, share the screen.
I did,
Oh, you did?
yes.
We don't see it yet.
Now I said join the meeting. Shall I do it again? I'm already there.
Okay, start again. It's not working.
Okay, join the meeting, sign up, then we lose a lot of time. But I am obviously there. I did. Here, your screen share is loading. Aha, this is what I see now. Shall I click on new share? New
Yeah,
share?
I see your camera now, but you don't have it turned on. You need. Okay, start again and click the button share is the first. There you go. You're sharing it now. Okay.
Is it?
Now
Is it?
pick
Great.
your screen you want to share.
I did. I'm already at the. Shall I click on new share?
No, you're not sharing.
So I click on new share. Okay, and then I click this screen.
The below of your or screen in your below. Click in the below, and you can to share that.
Yeah, click the share button first. The share button first.
Share button. Yes, it is called
Click
new
that
share.
first, and then you pick the screen you want to share.
Okay.
The below of your screen, you click and you can to share.
New share. Okay. So then I click on the.
Hasn't started yet.
So
Here.
shall I wait?
You have to click on the slide. Click on the slide now. The first slide. Click on that.
First slide.
Yeah, you're not clicking on the first slide.
Give me a break. I'm on the way.
There you go.
I'm on.
Okay, there you go. Now the presentation mode at the very bottom,
Yes, yes, yes.
right side. Yeah, you have to click the presentation mode.
You see
Hey,
it?
perfect, perfect, perfect.
So I'm sorry for this delay. This was the doctor's delay, and thank you very much for the introduction. I will talk about endovascular treatment of complex aneurysms, and as it was mentioned, I will show more cases in the anterior communicating artery region, but as Luis told me, I will also share my experience with new devices in the other parts of the brain also. So the first, how do we define the complex aneurysm? When we started endovascular treatment, I just count from GDC because the balloon was very, very long ago, but GDC was the first tool that we used. When we introduced this, then there was a definition of Fernando Vinuela that if the neck of the aneurysm was 4 millimeter, it was a contraindication for treatment. And it was a very early statement, but Jacques Boré introduced the remodeling technique. So it changed this, of course. We can treat much bigger, wider neck aneurysms now also. Fusiform aneurysms was also a contraindication, but with introduction of the stenting, it was not anymore contraindication. So it means that we develop new devices continuously, and it changed the strategies of endovascular treatment. So I will show you some cases, some older cases that can prove my statement. So this very first case, it's a Danish patient, I think, was treated by Jacques Moret 2004. The patient had a ruptured MCA aneurysm 2003 and an unruptured basilar tip aneurysm that Jacques treated. And if you watch this image, you can see, I think he used double balloons, because the shape of the coil, the packing shows that both PCAs were protected by a balloon. But by the time of the follow-up angiogram 6 years later, the aneurysm had a big reoccurrence. So when the patient reported to my hospital, this was the original image. And since Jacques treated this with balloon, I realized I couldn't do any better than he could, so I have to use another method. You see that the neck of the aneurysm is pretty wide, and the aneurysm is shallow. So the relation between the neck width and the dome is unfavorable. So my strategy was to put a stent here to the right PCA, then place a delivery microcatheter in the aneurysm and put another stent through the first one. So it's a Y-stenting to the other branch. This is the first stent, the right one. This was a neuroform. And the second one, it was an enterprise. And there is also the delivery catheter already before the second one placed in the space of the sac. And with these two stents protecting the parent arteries, it's very easy to perform the treatment, because then I just take a coil. First one should be big enough, long enough to go all around the peripheral portion of the aneurysm, and then finally treat the whole aneurysm, because I knew even if it looks like it would cover the neck and also cover the orifice of the left PCA, but we know that the stent will protect this. And this is the final angiogram, looks very nice. And I have a 5 years follow-up on this patient, exactly the same. Look at the lateral image where we covered both the anterior and the posterior aspect of the aneurysm, and it is remaining perfectly occluded. So this was a good method, and it could be used also for more complex aneurysm like this one. This is a giant aneurysm. If you see, the length of the aneurysm is 35 millimeter. The depth is 20, and the width is almost 20 millimeter. It has a huge mass effect compressing the brain stems. It's on the basilar artery, and the open portion is not so big. So the strategy here is similar. You see how big portion of the brainstem is compressed by this huge aneurysm. And the angiographic appearance of this aneurysm is like that. And it has not so easy anatomy as the previous one, because the open portion is very, very big and also deep. So to go to the right PCA, which is the more difficult vessel, the left is probably easy, but we have to start with the big one, the difficult one. I had to make a big loop with the wire and the microcatheter to the posterior portion of the aneurysm and go out to the right PCA. And then I could pull back the microcatheter without the wire and place the stent in the right PCA, and the other one, it was much easier to the left. And the tip of the delivery microcatheter is here, already placed before. So after placement of the stent, this is the aneurysm sac, and this is the sac completely filled by coils. Again, here it looks like the coils cover the orifice of the right PCA and the left, but we know it doesn't. This is the final angiogram, very good flow in the PCAs. And this is the follow-up at 1 year. And this patient was nice enough when I asked her to be available for a later control. This was the MR. So I have an 11 years follow-up with MR. And if you follow the size of the aneurysm between the 11 years and 1 year, you see that the aneurysm shrank during the 10 years. Patient is in very well shape. So let's go for the ACOM region. This is a 57 years old female. Oh, sorry, not ACOM. This is another one with seizures. This is also a giant aneurysm. It's in the left hemisphere. The size is more than 3 by 37 by, no, 42. This is the biggest diameter, 42 by 11 by 21. So if you look, the MR, a T2-weighted image, you see that this is a huge edema. This is that causing the patient seizures and headache. So when we made the angiographic image, then what we see is a pretty small open component of the aneurysm with the M2 branch arising from the sac, this one. And this image looks like a not very difficult surgical case. But if you think about that, everything is surrounded with a huge thrombose component, then you understand that surgeon said no. Although I used to work with a very experienced, good neurosurgeon, he said it is impossible to clip this aneurysm. So what we said, we decide to try to place a new stent, new developed flow diverter stent, and it was done 2008. So it was in an early phase of the flow diverters. Again, the orifice of the M2 branch here. So we put the patient on double platelet therapy, pre-medication. What you see after a week, the open component got twice bigger than the before. So it means that the thrombus inside the aneurysm was not a stable one. It was a dynamic change. So this is why this aneurysm keep on going all the time. And this is the angiographic appearance. You see the M2 branch coming behind the sac. And what you also see is that the way to the aneurysm was quite tortuous. So it was a challenge because at that time we didn't have soft tip guiding catheters soft enough. So it was a challenge to come up with the microcatheter to the M1 branch, but it was possible. And finally, I could place a small stent, silk 2 millimeter, 2.5 by 15 millimeter large. So it was a very, very short stent. And this is the result after placement of the stent. It slowed down the flow immediately into the open component, kept the flow open in the M2 branch, and caused a significant stagnation in the sac. So I was happy, it looked good. This is the final angiogram. All the branches are open. So the patient woke up and she was okay, unchanged. So we performed the follow-up at 1 year. Sorry, this is still this is the final angiogram with the stasis in the sac. This shows the good effect of the flow diverter. So 1 year follow-up. Now I was not so happy because I still saw the jet flow going into the aneurysm. The branch was open, okay, but otherwise the aneurysm pretty the same. I don't show you the MR image. Patient was okay. We performed a 2 years follow-up. Not much better either. Still jet flow in the aneurysm, but the M2 branch is open. At that point, we offered the patient a new flow diverter within the previous one to see if we can get a better effect. And she said, no thanks. She was happy. She didn't have any seizures anymore. So I said, wow, then we should not treat the image. We are also happy, but we wanted to have one more follow-up. And she said, yes. She came back after 3 years. And look at this. Look at that the aneurysm is gone. The branch is still open, but also the angulation of the M1 segment compared to the previous one, it changed. So the mass effect went back. And this is what we see. It's a very tiny, small branch, open coming from the aneurysm, and the M2 branch is open here beautifully. And looking at the CT, the T2 weighted image, there is no edema around. So the clinical result is very, very good. So all the edema gone. So this was a big step forward. So now we come to the ACOM, which is exactly what you mentioned. This is probably the most important junction in the circle of Willis. When the two big cerebral hemispheres, the circulation of these two hemispheres meet. So any difference in the vessel sizes here can be a cause to aneurysms. And this is a big aneurysm. What we see on the T2 weighted image is that there is a inhomogeneous signal in the sac. It looks like there are open flow portions of the aneurysm and probably thrombosed portions. It's a challenging aneurysm, difficult to treat, but also surrounded by edema. So there is indication. Patient had headache. This is the MRA image that confirms the two components that are open flow and the other one rest with thrombus here. And this shows the jet flow from the left side going to the right component, which is bigger, and from the right to the left. So what is the strategy here? Angiogram done from the right ECA confirms filling the left component first, then the right. And it also shows from the left one, the opposite, filling the right component first, and dominantly the left feels the right A2, and the right feels the left A2. So the 3D rotational image, the reconstruction shows that we watch the patient from above and from behind. So this is the left carotid, left A1, right A2. I took the line from here, from the left to the right, and from the right to the left. And these are the lines that show my strategy. So I wanted to place stents from the left A1 to the right A2 and right A1 to the left A2 to keep the flow open in the A2 branches and try to isolate the sac and fill them with coils. So starting from the left one, going into the big component, it's impossible to go directly to the right one because you cannot take this curve. So you have to make a big loop and go out with the wire. This is the Traxxas, very nice soft tip wire, making a big loop. And then the headway 017 catheter will follow, and then pulling back the wire, it will straighten up this loop. And then coming from the right, ICA going to the left. With the Traxxas wire, it's easier. There was no need to loop it and go up with the microcatheter. And when I have the two microcatheters here, I placed a delivery microcatheter from the left to the right, the big component, and another one from the right to the left big component. Sorry to making some issues with the sizes. It's not so easy to understand, but I want to make it clear for you. So now I have 4 microcatheters, and I start to place the stent, which is a Leo baby, 2 millimeter by 25 millimeter. This is a braided stent. It means it is very flexible and it has some flow diverter effect. So starting from the right A2, coming to the left A1, the first one, and the next one, starting from the left A2 to the right A1. So these stents they don't go through each other. They are just placed parallel to each other. And this is the flow. And here, what you see is that there is already a significant flow reduction. When I inject from the left carotid, there is much less flow in the right big component, which for me is a good sign. I'm happy when I do this because I feel that I feel confident I can occlude this aneurysm. So I started to pack the left component from the right with coils. And after 2 coils, the sac started to thrombose. It was not a good sign. I had to give intravenous platelet inhibitor, 60 milligram of integralin. I could reopen the vessels, the sac and the vessels, and then I continued and packed the whole open component of both sacs, which was 320 centimeter of coils, which is not so much, thinking of this such a big aneurysm. So this is the final result. And this is the angiogram, injection from the right carotid, the dominant filling of the left A2, and the little later filling of the right one. And this is the final angiogram, the full image. Again, little earlier filling of the left A2. You still see the mass effect of the aneurysm pushing the pericallosal arteries to the left. And from the other side, the same good flow in both A2s. Okay, good angiographic results so far. Patient woke up, he didn't experience any change. And I told him he wouldn't because the results should take longer time to come. And this is the 1-year follow-up. Injection from the right looks good, fully occluded. Injection from the left showed a little filling of the sac here. So for this reason, the neurosurgeon suggested we should do more follow-ups. And I said, yes. So we performed MR follow-ups, and the patient in the local hospital, different local hospitals in Denmark, he had at least 5 different follow-ups, MR, and all of them showed aneurysm remnant. So I was not happy with this result. So I asked, we take in the patient and do an angiographic follow-up again. So we did it 3.5 years after the treatment, and we injected both the right, no filling, and the left, no filling, and we performed 3D images also from both sides. So it excluded all aneurysm filling. So the aneurysm is completely occluded after 3.5 years. Very nice. Patient had no symptoms either. It was just psychologically bad for him to get the results from MR. But we realized that MR does not always show the real result. Another big ACOM aneurysm, also partially thrombosed. We call it giant because very big size, also edema in the surrounding brain tissue. Angiographic appearance, injection from the left. This is a 3D reconstructed image. Left A1, left A2. So the aneurysm is coming from the right A1, A2 junction. We don't see it because of the sac is front, but from behind, we see that there is a neck area here. So the strategy here would be easy to place a stent here and fill the open component with sac, with coils. But I couldn't do it because of the neurosurgeons, because they saw this aneurysm being a good surgical candidate. To analyze the angiogram again, here we see the injection from the left and the jet flow going into the sac, and from the sac coming the right A2 little later. And there was also a smaller A1 from the right side, also could feel the right A2. So for me, it was a clear cut, but surgeon wanted to operate. They are stronger. I couldn't resist. So they performed and clipped the aneurysm November 13, and this was the follow-up May 14, 6 months later. What we see, there are several clips here, probably 4 or 5, difficult to count. The aneurysm is still quite big, and the surgeons, they confirmed that all the clips were at the neck area at the placement during the operation, but this was the result after 6 months. So they said, okay, the case is yours now. So thank you very much. So I performed the new angiogram, and to my surprise, it showed that the anatomy changed significantly, because this is the left carotid injection, showing that the right A2 is going into the sac first. There is a smaller component of the sac, and the right A2 feels from this sac. And there is also another big sac, so the anatomy became much more difficult than it used to be before. So what can I do here? I was a little bit unsure, because I cannot go from here directly to here. It's difficult. When we analyze the flow, injection in the left ICA, the jet flow goes into the sac, first filling the first smaller component, then the big one, and from this point, filling the A2. So what I could do is that I went around with the wire in the first loop very carefully and pushed out the wire to the A2. And then I could follow with the microcatheter, which is a soft tip microcatheter. And during this, I could place a long exchange wire and replace the microcatheter with the balloon. And inflating the balloon, I could carefully pull back. This is a double lumen balloon, the scepter. I could pull back the catheter and straighten up this loop. This is very important, because when I did that, I could go through this balloon with the with the stent, the Leo baby, and this is the component that I straightened up. You see here, it is a little bit compressed, but it is straight. And the angiography shows slow flow into the sac. This is due to the flow diverter effect, immediate flow diverter effect. Later on, good flow in the A2 and stagnation in the sac. So this was a good but not good enough result. So I put another small flow diverter, little bit, Leo baby, shorter than the previous one, just to cover the neck, because now it was stable with longer portions in the healthy branch of the vessel. And this made a much better flow diverter effect with very slow filling of the sac, good filling in the A2, and significant stagnation in the sac. So I was happy with this, and this is the final angiogram. Patient was discharged, unchanged, no neurological deficit, and this is the follow-up 18 months. What you see here is that the sac is not visualized anymore, so it is thrombosed. Both branches are nice, open, good flow. And this is the appearance of the Leo babies. You see, they could reopen the vessel. They are very nice, no compression of any part of the stent. And the flow is also very nice through the stent. Here was the neck of the aneurysm. So there is no discongruence in the branch. Very nice, good result. So Luis asked me to show my experience with the new devices. So now I will show some cases with the new devices. One of them is the neck stent. This is a braided nitinol mesh disc. We place it inside the aneurysm at the neck to support the coils. It looks like a part of the brow. So it's bulging out a little bit through the neck and covers the neck. It consists of 64 wires, comes with 4 sizes so far, 7, 9, 11, and 14 millimeter diameter. It can be delivered from the 0.0 to 21-inch microcatheter. The smaller ones, the bigger ones need a somewhat bigger microcatheter. And the mesh is very tight in the central portion, but in the peripheral portion, it can be passed with a small delivery microcatheter. And initially, we thought that we have to go through the stent, but later on, we changed our strategy. So we go around the stent. So we jailed the microcatheter like we do with stenting, which is much easier now and makes it faster and less complicated. So the device is retrievable, repositionable until I am happy with the result. And usually I detach electrically detachable when the treatment is finished. So this is how it looks like. Again, 64 wires. All the wires come from one concentric assembly point. So you can imagine that these are very, very tight mesh here in the central portion and somewhat less tight in the peripheral portion. 64 wires. If it is a flow diverter, it goes around the vessel, but here it is just in the aneurysm neck. So it's a very, very good flow diverter effect also. This is how you can cross it with the microcatheter and deliver microcoils within the sac, and this will keep the coils in the sac. So let's see how it works. This is the first in-man case done 8 years ago. Wide neck basilar aneurysm. Patient was already operated for an ACOM aneurysm. Here a clip. Again, the neck dome ratio is very unfavorable. Both branches are engaged, both right and left PCA. Very difficult to place coils without occluding these branches or probably the basilar artery. So placement of the device is very easy because the basilar artery is straightforward. Here you can see the device, how it looks like, still attached to the pushing wire. This is the assembly point. So at that case, this is how the look angiographic look after the placement. And this is when I could go through the stent with the microcatheter. It took me 45 minutes, very difficult to push. And then I said, we have to try to find another solution. So since then, I never did it again. I always push the microcatheter first and then place the device afterwards, which is much easier. So then it's easy to fill the sac with coils. This is the final. When the neck stent is detached electrolytically, this is the look. And this is the angiogram. You see both branches are open again. The coil mass comes deep down in the parent vessel. You would expect it would be occluded, but it is not because the device has a conic shape, so there is enough space around. 5 years follow-up, 5 months follow-up. It looks good, but the right PCA is not filling. I got some criticism when I showed this case in Val d'Isère. Oh, you placed the device and you occluded the right PCA. This is not good. No, I didn't occlude. I just changed the flow because the right PCA had a direct orifice from the right carotid. This is a fetal orifice. So I just changed the flow dynamics. So there is no problem with the patient, no deficit, and no clinical sign of any problem. So the result is good. And I have 8 years follow-up on this patient. The aneurysm is still occluded. Very nice result. This device can be used everywhere in the brain. I will show you an MCA aneurysm. Very difficult to define the neck because it's wide in both directions. Both those two MCA branches, but also very wide here. So even if we place 2 stents, it wouldn't be sure that we could cover the neck. With placement of one neck stent device, however, this is the 7 millimeter, you can here see, we pull down to the neck, deep down in the bifurcation, and place, this is just one coil, and then I placed another one, short one, the aneurysm was occluded. This is the final angiogram. You see no inflow. And this is the aneurysm at 7 months, also no inflow. And interesting that the packing density is not very high, but this relatively low packing density together with the flow diverter effect of the neck stent makes the aneurysm totally thrombosed, and all the branches are nicely open. Now, a much bigger one on the same location. What you see here is that the bifurcation of the M2s, M1, M2 bifurcation is not visible on this image, and not here either, because of this component and the bleb that is bulging down. So to understand this, we have to analyze the 3D reconstructed images. And this is the right M1. You see the patient's position here. This is a tilted AP. So the bifurcation is somewhere here behind this bleb. And these are the M2 branches coming from the neck. Difficult to understand, but if you understand, then you have a strategy. And you see here the neck is more than 10 millimeter wide. Here the body is 14 millimeter wide. So it's a big aneurysm, difficult to cover with anything with the neck. This is the the lateral image. And my strategy was to place the biggest neck stent here, put the delivery microcatheter that way. So this is my final strategy, to place the tip of the delivery microcatheter pointing downwards, because then the coil will come to the neck area first and then feel. If I feel the neck area, the rest will usually thrombose. So this is the starting point. The neck stent is already placed here, very nicely covering the neck. And then this is the angiogram, a little bit slower flow after placement of the neck stent, stagnation in the sac, filling the bleb here in the later phase. And also this is the lateral image, filling the...
5 minutes.
5 minutes, okay, I go on. So this is how I get the coil come to the bleb and fill the whole aneurysm. And this is the last portion when we see the image, the neck area. And this is when I pull back the delivery microcatheter after placement of all the coils. It was so tight, so when I pulled it, it pulled the whole aneurysm, but it was not a problem. I could retrieve it. This is the final image. You see the branches open. There is a component still filling with some contrast. Final angiogram. And this is the follow-up at 20 months. Both branches are open. The component here thrombosed. Beautiful result. So I will show you the sister device of the neck stent, the contour, that has even more wires, 144 instead of 64. It gives 33% higher area coverage compared to neck stent. It means that it will work without stents. So this is an ACOM aneurysm, wide neck, asymmetry between right and left, A1, and placing the device here, 9 millimeter contour. After 10 minutes, it will close the whole aneurysm and also close the right A1. So it looks good, but I was a little bit scared. So I put another catheter in the other groin and performed the angiogram through the right carotid to show this small A1 fills the A2. So then I dare to detach the device. And this is the final angiogram, very nice. And this is the 6 months follow-up. Again, completely occluded aneurysm, small filling of the right A1, also A2 here. So very quick, I just show you a similar case, basilar tip aneurysm occluded with contour. Waited 25 minutes to detach, and a very difficult MCA aneurysm where I had to place the device deeply in the parent artery with the tip here. And here I waited 40 minutes to detach, to see that the flow was open. It was nice. And this is the final angiogram. 7 months follow-up, didn't occlude yet. Why? Because I had to extend the double antiplatelet therapy, because this aneurysm caused a small minor stroke for the patient because of the very, very big portion of the device being outside. But follow-up at 18 months, it was occlusion of both the basilar and the MCA aneurysm. Beautiful result with a very, very small remnant here. Okay, this is the last case. This is a difficult, tricky MCA aneurysm, fusiform, with a young patient. This is the angiographic appearance. 2 branches coming from the fusiform portion. And it was a difficult, I said the patient, the best one is not to treat. She accepted this, but she changed her mind, female, 3 months, 4 months later, came back. So what I can do, flow diverting, double stenting, or flow reversal. I thought flow reversal was probably the easiest one. So I put a balloon here in the other M1, M2 branch and checked the flow, which was okay, but not perfect. So I said, probably if I try to place a stent through the fusiform portion from here to here, fill with coils. This is the enterprise stent. Place coils around the stent, keeping the branches up and down open, like that. I could save the flow and I could occlude the aneurysm, and it looked good. This is the final angiogram. She had transitory aphasia after placement of the, she was protected, of course, with clopidogrel and salicil. She was discharged the 3rd postoperative day, and 6 weeks later, the clopidogrel was stopped by the family doctor, which was a bad decision. So she got some TIAs 3 months later, and then she came back 6 months to do a follow-up angiogram. It showed that the lower branch was gone. That was not nice, but she was asymptomatic, and we performed MR, and MR did not show any ischemic issues. So I come to my conclusions. Endovascular treatment of this complex aneurysm, it should be based on careful analysis of the DSA images, including 3D array, evaluation of the flow dynamics in the adjacent vessels, and the need of blood supply of the brain tissue downstreams. It should be performed by physicians with enough experience with the pros and cons of the available state-of-the-art devices and the tips and tricks regarding their use. However, if you don't have access to or funds to these fancy devices that are expensive, use your brain and experience, because sometimes the best treatment can be parent vessel occlusion, if it's on purpose or delayed, because it will never recur. Many thanks for your attention. I'm done.
Thank you very much. Thank you very much. Fantastic. Okay, Reynaldo.
Okay, Professor. Yeah, you would want to continue, Professor, with the...
Yes. John.
Yes.
You help me? Compartir.
Hey, listo.
Ya está. Compartir.
Esperando para ti, Luis.
Ya está. Just a minute.
Right.
It's okay, no?
Yeah,
Hey,
yeah, perfect.
perfecto.
No, this is the last,
Yes,
just a minute, I put the first.
I'm back.
Okay, I thank you, Gyula, for your presentation. I present the 3 case. The special case, no, is different. It's very interesting your presentation because you wait. When you treated the aneurysms, you wait. You know, you are hysteric to treat it too close, too close. You wait. Sometimes you wait 1 month, 20 minutes, 3 years, and the evolution is fantastic. I think I learned this your feeling.
Thank you very much.
Okay.
Yeah.
This is a small aneurysm. Every small aneurysm of the anterior communicant or posterior or whatever you want, I use the technique, the balloon remodeling, because it's most easy to pack in the coils, and also see you have a spasm, also see you are the rupture, you are more control. When I use the balloon remodeling, I don't anticoagulation because I work very fast. So the procedure is more than 30 minutes, I anticoagulation. This is the balloon. I inflate, deflate. And this is the final control. This is sample. This is my standard technique. Another have too many aneurysms. This is the important to treat. Also, same balloon, remodeling, and coiling. And the second aneurysm, second balloon, and place more coiling. This is one case, have a thrombosis of the left carotid artery. And the aneurysm going the right to the left. It's important to check every time where is the Hebner or recurrent artery. And this is the work position to the work position. You see the communicant, you see the aneurysm, both anterior cerebral artery, A2, and no, sorry. Okay. I put the balloon in the inferior branch, the coils, and then I put a stent. I place one stent, only one, more coiling, and there's the final result. But this is one case with the origin of the A1 in the left side, have a small stenosis here. The distal part of the siphon in the junction with the A1, you have small stenosis. When I place the stent, you have here a small kinking. And the control is okay. It's okay, totally occluded, but 8 hours later, have ischemia. In this moment, I go to the angio suite and balloon remodeling to stop this ischemia. I hear more smaller spot, but the patient going well. This is balloon to dilatation of this part of the thinking. This is another case, 8 months year old, have a frontal and subdural hematoma. And initial angio in emergency is negative. Don't have the vascular malformation or aneurysm. The control angio, 3 months later, you see here 2 dissecting aneurysms, 1 and 2. And the left anterior pericallosal artery is atrophic because you are here the lobectomy. And it's impossible to place one catheter the normal size. I decide to navigate with a small catheter, magic, and inject in this part to this part onyx. This is the control. You are totally occluded here and collateral circulation, no deficit and cure. 8 months. This is the final case, 2-year-old boy, grade 4, when arrival from the hospital, bleeding, and I have a very complex pericallosal fusiform aneurysm. This is the AP view, and this is the lateral view, oblique view. In the junction, the A1 to A2, you have the pericallosal fusiform serpentinous serpentine aneurysm. The patient is by general anesthesia. It's impossible to test, clinical test. I decide to coil the neck, place the coiling just in the neck, and you are here, a stagnation of the contrast. The coil is here, and this is the aneurysm. But you see also, at the same time, you have the leptomeningeal collateral circulation going just from this. I decide to liberate the coil. This is occlude the aneurysm, and this is the collateral leptomeningeal reversal flow to this part. This is the initial. This is the control lateral. The control lateral. 3 months later, the control. Look, the reconstruction of the vessel, but not more aneurysm. This patient is treated by myself in 2000, no, before 96, 97. And this is okay. Okay, this is, okay. Thank you for your attention. Is only present this special case. Okay, to discussion.
Very nice, Luis.
You like?
Yes.
Making a summary is I'm facing this cases of complex aneurysms. The treatment involves two main approach: endovascular coiling and surgical clipping. Um, I want to mention the since the international subarachnoid aneurysm trial endovascular recurrence has been the primary treatment modality. However, surgical clipping remains indispensable managing the complex aneurysms. A question: in a lot of places of the world, we don't have this kind of devices or technology. What do you think, Professor Gyula or Professor Luis, about how do you face this kind of, in the case of both professors, for me, are monster anonyms. If you don't have all the technology or if you don't have all the complex devices, uh, how how do you face it, this kind of the complex aneurysms?
Gyula, please.
Yes, thank you. As I showed you, if you remember the last case, I did it without any big complex devices. And I also, what I learned from Jacques Moret, who was my teacher, is that if you have a chance to perform parent artery occlusion, which in his time, it was done with balloon, nowadays mostly with coils because balloons are not available. Many times we can get very good results with parent artery occlusion. It is cheap. We have to test if the patient tolerates this, either in awake or in the general anesthesia to see the flow dynamics. And we can occlude most of the vessels with 2, 3, 4 coils permanently. And those results will be remaining for forever because occluded vessel will never reoccur. So what we try now to do for younger patients with flow diverters and with neck bridging devices to keep the vessels open, but it is not absolutely necessary. So in my more 35 years of experience, quite few cases when I saw new aneurysms after occlusion of a parent artery. It may happen. So it's still, if we have the devices and if we have money to buy them, it's nice to have, but if we don't, we can occlude a parent artery if the patient tolerates, and we get in 10, 15 years very good results. This is my opinion.
Okay, thank you so much.
Yes, I agree. I agree with you, Gyula. Is every patient is different, but I think it's important every time test the possibility to occlude the vessel. Only this, and then do you use one material or the device wherever you want? Because if you have a problem, final problem, it's possible to close the vessel.
Yes.
And I think I like to study before perform the embolization. I have studied with the anatomical situation. Why not your case is thrombosis the cerebral posterior and then open the cerebral is still here. Okay, it's fantastic. One question, and I finish because I need to go out. One question for you, Gyula. The Kaneka, do you remember? What do you think with the Kaneka? I explain a little bit for the people what is the Kaneka device.
Thank you very much. This is a wonderful question because everybody asks me, wondering, why do you use the Kaneka coils? The explanation is very simple. The Kaneka coils are thicker than the other one. It's probably 40% thicker, so it's more material. It gives more volume for the same money, so it gets 40% cheaper coils. This is my reason. The coils are very nice. The coils are robust. They have also very small, thin types, but the bigger ones, these are really robust coils that will be there where I place them. So this is the simple reason. I don't get any reimbursement from the company to do any marketing, but you know, for people where they have to count on money, this is a good option compared to the other ones. This is my
Gyula, you are tested the fiber coil from Dendron. You remember?
yes.
The fiber coil, the Hankins. Do you remember the fiber coil? Fiber coil
Yes.
from company Dendron.
Yeah, it was long
Hankins.
ago.
Do
It was
you
very long
remember?
ago. Yes, I
You have
remember.
more thrombosis
Yes,
of the platinum
exactly.
coils.
The
I think
problem with
I think in my experience, the secret is combined. You combine
yes,
you have the basket and then you put one of the coiled Kaneka was.
there is another very nice coil that is covered by something that is called shape memory medical, and it makes the coil surface 100 times bigger. This is wonderful, but the company is a small American company, and when
Yes.
the peripheral people discovered the advantage of this type of material, they wanted to have everything available, so they had to put the endovascular, the brain procedures on hold. So I've done probably 60, 70 cases, but I don't show any cases now because the coils are not available. I hope in the future they will, because much less coils also for the fistulas, very easy to place, and they close the big aneurysms much quicker because they produce immediate thrombosis after sex. So there are many good options.
Yes. I know one coil is a fake coil. Do you remember Matrix coil?
Yes, that
It's a
was a
fake because
disaster.
it's contrary, because it's acute thrombosis and
Yes.
then regression
Yes.
the thrombosis and recanalize.
I didn't remember you any case here that I don't have at least 7, 8 months follow-up, because otherwise this is just bullshit. We should not use
Okay,
those.
thank you very much, John, Gyula.
Yeah,
See you the next.
excuse me, Louis. I think Suresh Narain may have a question, or Suresh, do you have a question or comment? Go ahead, Suresh. It's all yours. Please introduce yourself and ask your question.
Yo tengo que irme. Yo respondo.
Suresh,
Okay.
you there, Suresh?
Hello, yes. Say there is no doubt that these aneurysms are complex for both the endovascular people as well as the operative techniques. And the endovascular, you have come out with lots of devices to tackle these aneurysms, and these are very nice cases you have demonstrated. There are few challenges which are there in the ruptured aneurysms. You have to give dual antiplatelets. That's a big problem. If an aneurysm is coiled or clipped, there is no problem. Because in coiling, you are not giving the dual antiplatelets or even a single antiplatelet. But in a ruptured aneurysm, giving the dual antiplatelets is the problem. But if it is a complex aneurysm and the neurosurgeons are unable to clip it, then obviously we are not left with any choice other than subjecting them to the endovascular techniques. But what you have come out with the intra-aneurysmal devices like your neck stent and your contour device, in these probably I was told by my endovascular colleagues that subsequently you may come out with single antiplatelets also. Then in that condition, these things may be more effective. That is one. And what Dr. Louis has told about the balloon thing. In this balloon, you are just putting the balloon and then putting the coil. So the antiplatelets are not required. So that is good. But putting the dual antiplatelets may be a problem sometimes. And these all MCA aneurysms which you have shown, these probably by the configuration we can try and clip that also, though we tried in one which you have shown, and in that ultimately you have to coil it. So it has to be a joint venture which has to be done. Now about the say the parent vessel occlusion. parent vessel occlusion and bypass may be the other alternative by which these complex aneurysms can be tackled. Then the aneurysm which you have shown, the giant aneurysm of the basilar, in that there was a large component which was thrombosed and there was a small component which was filling. You have put the coils, many a times what happens that you put the coils, there is already a clot, plus there is a coil mass which is there, and it compresses the aneurysm and the patient deteriorates. Then we may have to operate also. So what I want to tell you is that both the techniques are to continue. The expertise in the small aneurysms and the say the non-complex aneurysm by operative technique also should continue. So if there are situations with the endovascular thing coming up, the problems, these complications can be tackled by the neurosurgeons. I think both Professor Louis and Professor Gyula will agree to me on this.
Of course, since I see that Louis had to leave, I fully agree with you. And I just want to tell you that in the setting of the ruptured aneurysms, I do the same as Louis showed, to put a balloon and try to pack the aneurysm with coil. If it is impossible, I ask the neurosurgeons to put the drainage first, and then if I know that the aneurysm is extremely wide-necked, I place the coil first and I place the stent at the end and don't prepare the patient with antiplatelets, just give it intravenously at the time when the aneurysm is already packed with coils. So this is the way. Also with the next stent, sometimes we have to use it when we cannot do it with a balloon, but most of the time it's doable with the balloon. The reason I didn't show you that kind of cases is that Louis told me that please try to show you the new devices.
The excellent demonstration of the new devices. The last question which I wanted to ask you is that what is the difference in the neck stent and the contour device? What's the difference in these two?
It is also a very good question. Thank you very much. The reason why I use a neck stent compared to the contour is that if the neck is that shape, like a plate or like a draw, I cannot put the contour that will fit in the aneurysm, because the contour needs to get this kind of friction. If the neck is wider, I place the neck stent because it can keep the coils inside the aneurysm. And what you saw is that I can fill the whole aneurysm with coils, and the long-term result is very, very good. So change the choice between neck stent and coil depends on the angiographic architecture of the aneurysm. This is my practice.
So once you put the contour device or the neck stent, which is the intra-aneurysmal device, do you think that the dual antiplatelets will be required still?
I give it because I had some minor strokes when I didn't. So since the aneurysm is completely occluded, I don't see any drawbacks using double antiplatelet. But if there is an acutely ruptured case, then probably we don't need to give long time. Probably it's enough to give for a shorter time. This is, I think we can make it more individualized, but I think it's major risk if I leave a thrombosed part in the blood stream, which is not protected in that patient. So this is the reason I prefer to give double antiplatelet.
Is there any work going on that these intra-aneurysmal devices which are being placed, they are impregnated with antiplatelets, so there is no need to give the systemic antiplatelets? Is there any work going on that?
That would be very nice, because many of the stents have this kind of coverage. These devices are relatively new. It takes longer time and quite much money to develop the tools to cover those devices, but your point is very good and very valid, and the industry will work on it, I'm sure, if they see there is money. But we don't work for money, we work for the patient.
Yes,
industry
that's
works
true.
for money, and they have to make enough profit to be promoted to do anything. So
say, obviously, you are not working for money. That is the reason that I don't differentiate between operating neurosurgeon and endovascular people. I don't call them endovascular people. I tell them they are endovascular neurosurgeons and we are operating neurosurgeons. You are
thank you
also
very
equally a
much.
neurosurgeon. Yes.
Thank you I am very happy for this promotion. Thank you.
Thank you so much, Professor. He has a very great meeting, and thank you so much for share your experience. I am very interested for your cases are very monster aneurysms, and I am in Latin. And my perfect technique is to do the jailing technique for me. It's a functional and very good over in the complex aneurysms. But thank you so much for your connection, for your share your technique and your new devices and technology. And thank you, Professor Bennett, for broadcasting from Miami, USA. Thank you for everything.
You know, I would like to, I'm a non-neurosurgeon, Dr. Gal, but I will also give a compliment to your field because Gyula, I first met Gyula in Spain at Lewis's lecture. He had a lot of respect for neurointerventional radiology because he came every year to Lewis's webcast. So he had to believe in it. And also Bin Zhu from China made a special effort to go to Lewis's webcast. So those two giants believed in your field. So there's got to be something to it. And I appreciate it. You coming out this week, Dr. Gal and Lewis. We'll see you again. I guess you have to step away. And Ronaldo.
Once again, they are not endovascular radiologists. They are endovascular neurosurgeons.
Okay. Well, you're dealing with cases we just talked about. So
that's what I tell them. Once you
going
associate with neurosurgical problems, you are endovascular neurosurgeon.
Okay, very good. Okay, we're going to see you in 2 weeks with Dr. Hanel of Jacksonville. He's going to talk with Lewis about what he's doing in Jacksonville. And we'll see you in 2 weeks. Thank you very much.
Thank you very much for hosting me and for the invitation. Thanks organizing for everything.